Good evening. I'd like to just welcome all of you to today's Satellite Symposium. This is a Satellite Symposium sponsored by Novo Nordisk. So would like to begin. So those who are still outside, just like you to come in and we can start this Satellite Symposium. So as you can see, Novo Nordisk has been the champion of quite a number of endocrine related diseases, especially on growth hormone as well as diabetes. So for this evening, we're going to have an array of very important internationally recognized speakers who's going to talk to us on this topic on Novo Nordisk footprints in pediatric endocrinology. So my name is Muhammad Yazid Jalaluddin. I'm a professor of pediatrics from Nusa Malaya Medical Center in Kuala Lumpur. And this is my disclosures. I have to admit that I was PI as well as the PI in a number of studies by Novo, and was involved in the most recent publication in NEJM for the liraglutide for those children between 6 to 12 years. So basically, somapacitan, as we know, has been approved by FDA, EMA, and CDSCO, indicated for the replacement for endogenous growth hormone in children and adolescents with growth failure due to growth hormone deficiency, and in adults with growth hormone deficiency. And in Asia Pacific, somapacitan is available for prescription in Australia, New Zealand, South Korea, Japan, Hong Kong, and yet to be launched in India. So this material is intended to be used at the APAS 2024 13th Biennial Scientific Meeting. So let me just go through a bit on the objective of today's symposium. So basically, when we look into the growth hormone deficiency, what we would like to address is the unmet needs in growth hormone deficiency and the rationale behind once weekly growth hormone treatment. And we would like to communicate the results from the pivotal trials that I'm sure Prof. Varman and Cook has been, has completed it on REAL 3 and REAL 4 on the use of somapacitan in children with growth hormone deficiency. And then we will delve into the optimization of somapacitan for pediatric growth hormone deficiency, focusing on the IGF-1 response. I'm sure a lot of questions on how and when do we check the IGF-1 when you are going to use growth hormones once a week. And moving forward, after about an hour, we're going to look into the type 1 diabetes, especially looking at the gaps of the next generation insulin to address and analyze the evidence supporting the use of ultra-long and ultra-fast insulin in children. This is the agenda of today. Just going to give you a little bit of introduction, followed by Professor Dr. Varman, who's going to talk to us on somapacitan in children with growth hormone deficiency, insights from REAL 3 and REAL 4, and Prof. Barry Miller, who's going to talk on the optimizing somapacitan for pediatric growth hormone deficiency, IGF-1 response, dosing and monitoring, before we go into the Q&A session. Once we finish for about 1 hour on growth hormone, then we'll delve into the managing type 1 with new generation insulin by Dr. Achana Arya. And again, we're going to have a Q&A before I do the closing. All right. I would like to welcome both our speakers on stage. So Professor Dr. Varman, Senior Pediatric Endocrinologist from Jehangir Hospital, Pune. He's also the Honorary Pediatric Endocrinologist at Bharati Vidyapith Medical College at Pune. I actually got to know Prof. Varman some time ago when I was looking at the growth chart. he's the man when we talk about growth chart. So anything about growth chart, I think he's the person, and I'm very happy to be chairing the session today for someone with that kind of stature. So Prof. Bradley Miller, I think I only quite recently know him, but I'm very impressed on how much understanding that he has when he talked to us about the IGF-1. So Prof. Bradley Miller is the division in the Division of Endocrinology at Department of Pediatrics, University of Minnesota Medical School. I think he holds a lot of, he holds a lot of grant as a PI as well as the thinker, I would say. Yeah, expert panel on IGF-1. So let me just start briefly on the need for a weekly growth hormone. We all know this. We take care of patients with growth hormone deficiency and those patients who need to be put on growth hormone. And we know patients with growth hormone deficiency, the main issue is a growth failure. And there's growth retardation whereby they have all these issues of short stature where the height SDS is -2 standard deviation below the mean, below the population mean. And we all know growth hormone does not just give you the height, but also lead to the issues of unfavorable body composition. We understand that there is a decreased muscle mass as well as increased fat mass. And I usually take photos of my patient before 3 months, 6 months, 9 months, 12 months after they start on growth hormone. Then you can see the difference, not just in terms of the height, but their facial features as well as their whole body. Some of them do have delayed development with immature faces, delayed dentition as well as delayed puberty. And on top of that, we cannot forget the issues of impact quality of life, whereby they have this potential negative psychological and behavioral impacts, especially those who are quite good in sports, but because of the issues of height, they usually are not so well to do when it comes to comparing themselves in terms of sport for the age group. Yeah. And we also understand about the injection schedule and the pains that has to be there for children who needs to inject themselves every night. Study in Italian population involving patients and caregivers, as you can see on your left side. Yeah, the injection pain and the need for daily tasks were considered burdensome in growth hormone deficiency. So I think if we were to be given the choice of giving ourselves once a day injection, we probably opt not to have one. So that's the same thing when it comes to these children and the parents. And the study in the United States, as you can see on your right side, again involving children and adolescents, suggests that the injection schedule is the key factor driving patient preference for growth hormone injection. And 0% of the children and adolescents prefer once daily injection if other dosing frequencies options are available. So that's really telling when it comes to growth hormone treatment in children with growth hormone deficiency. So what is the consequences, of this non-adherence to growth hormone therapy? So it's definitely significantly lower the final height outcomes because you don't get it like what you should be getting it every day. It may also lead to further diagnostic tests because for us, when we see our patients not growing, we would like to find out what are the reasons that made them not growing. And because of that, the potential of the false diagnosis and unnecessary change to the drug dose as well as the increase in the healthcare costs. Not to mention when you have this once weekly injection, there will be definitely a reduced number of injections in growth hormone treatment. And this will definitely improve adherence. So if we look at the perspective on the long-acting growth hormone from the medical scientific societies, we would like to look into the comparability with the current daily growth hormone, as you can see from all the one in the blue, whereby the cost effectiveness is there, the similar tissue distribution, which Prof. Vaman will look into more detail later. The mean IGF-1, Prof. Bentley will again shed us some light. Improvement in adherence, side effects, which is similar or of the same duration as the daily growth hormone. And there's also a need for us to look into the delivery system. The small injection volume is not about 7 times the volume of the daily. Yeah, please put that in mind. That no one will actually give you that 7 times volume when it comes to a once a week injection. Yeah, it's still a small needle which is suitable for the use of a pen device. So for that matter, I'm going to call upon Prof. Vaman to talk to us on somapacitan in children with growth hormone deficiency, insights from REAL 3 and REAL 4. Prof. Vaman.
Thank you, Professor Jalaluddin. Good evening, everyone. And I'm here to tell you about the REAL 3 and REAL 4 somapacitan clinical trials. Now, these are my disclosures. So I work at Jahangir Hospital, and I have been involved with the research trials as principal investigator for Novo, Nordisk, Pfizer, Sun Pharma, Eli Lilly, and company. And I have received honorarium from Novo Nordisk, Pfizer, and Sun Pharma over last few years. So coming to long-acting growth hormone, and many of us in India have started using some long-acting growth hormone in the recent times. But there are mainly 4 types of methods to prolong life of growth hormone in the human body. So you can either have pegylation, you can have depot, you can have fusion molecules, and you can have albumin binding. And the one that we are going to talk about today is the albumin bound molecule. Now, this is the structure of the somapacitan molecule, and this is a time-tested method that Novo Nordisk has been using to prolong the life of their other molecules such as insulin. And I won't go into great details of this because Professor Bradley Miller will cover some of it in his lecture. But primarily what you're looking at is that there is an amino acid substitution which is not in the GH receptor binding domain. And then you have got a hydrophilic spacer and an albumin binding moiety. That's the structure of somapacitan molecule. I would now be telling you about phase 3 and phase 4 clinical trials. Now, those which are shown here in light blue color are the ones which are already completed, and those in dark blue color are the ones which are ongoing. So REAL 3 is concluded. REAL 4, 5 and 8 are the trials in which I am involved at Jahangir Hospital in Pune. And REAL 6 is not there in India. It was meant for China. Now, REAL 3 trial is a phase 2 trial. And the design of this study was, it was a multinational randomized open label dose finding trial. So this was a dose finding trial, and there was a 26 weeks main period and 26 weeks extension, and then a 6-year safety extension. Now this was done on children, boys and girls, pre-pubertal, growth hormone deficient children without any prior exposure to growth hormone therapy or IGF treatment, who had a height standard deviation score below -2 SD for the local standards. And the objective was this study was to find out what is the optimal dose of depot growth hormone. And they, on one arm, they received daily growth hormone, and on the other, there were 3 dosages of somapacitan, 0.04, 0.08, and 0.16 milligram per kilogram per week. Now, this is the design of the trial, where, as I said, that at the onset, you have got one arm which is daily injections, and then you have three dose determining arms. So 0.04, 0.08, and 0.16. That's a 26 weeks main phase and 26 week extension phase. And then all those who were on varying dosages in the subsequent extension have gone on to a single dose, which is 0.16 milligram per kilogram per week of somapacitan, and continued to have the same dose of daily growth hormone, which was 0.034 milligram per kg per day. And in the long-term safety extension, they were all on 0.16 milligram per kilo of somapacitan. Now, sustained efficacy and safety were demonstrated for somapacitan up to 4 years of treatment. And what you see here on your left-hand side in the graph is the height velocity at 52 weeks in 3 differing dosages of somapacitan, versus the last column that you see is the daily dose of growth hormone. And as you can see, the response is dose dependent, with the maximum response being at 0.16 milligram per kilogram. So at 52 weeks, significantly greater height velocity was seen with somapacitan at 0.16 milligram per kilogram per week. Average IGF-1 for somapacitan at 0.16 milligram per kg per week matched the daily growth hormone injection arm. And following 4 years of treatment, efficacy was maintained. Now, this is the sustained efficacy and safety that was demonstrated for somapacitan up to 4 years of treatment. And as you can see here, after 1 year of therapy, the distribution of adverse event for somapacitan was comparable to that of daily growth hormone. It was well tolerated at all 3 dosages, and no new safety concerns, signs, signals, or tolerability issues were identified at 4 years, including in patients who switched from daily growth hormone to weekly growth hormone. And no neutralizing anti-human growth hormone antibodies or anti-somapacitan antibodies were detected. So that was REAL 3 trial. Now moving on to REAL 4 trial. Now this is a phase 3 trial, and the design of the trial was, it's again a multinational randomized active control open label double blind 52 weeks trial plus 3 years safety extension. The participants were again boys and girls prepubertal with growth hormone deficiency, no prior exposure to growth hormone treatment or IGF-1 treatment, with a height Z score below -2 SDS. And the objective here was not dose finding, but to look at efficacy and safety of somapacitan. And again, there were 2 arms, somapacitan and daily growth hormone. And this was the design of the trial. As you can see, 200 prepubertal children. There were 2 arms, daily 0.34 milligram per kilogram per day versus somapacitan 0.16 milligram per kilogram per day. That was the main trial for 52 weeks, followed by only somapacitan 0.16 milligram per kg per week for up to 3 years. Now, if you look at the baseline characteristic of the patients enrolled, somapacitan obviously had the larger number of 132, and daily growth hormone was 68. There were 75% boys in both groups. That's the distribution of different ethnic groups. Mean age was 6.4 years in both groups. Height was comparable. But height standard deviation score in the daily growth hormone group was lower than that in the somapacitan. IGF-1 was comparable, and the peak GH was also comparable. Now, this slide shows you that somapacitan shows non-inferiority as compared to daily growth hormone. And on the left side, what you see is the annualized height velocity in centimeter per year. So it's comparable to daily growth hormone, and there was no statistical difference. And similarly, if you look on your right hand side, you see that at 0, 13, 26, 39, and 52 weeks, there is very marginal difference between the 2 treatment arms. They're comparable. Now, secondary height endpoints supported the same results as earlier from the primary endpoint. And here on your left hand side, what you see is height velocity standard deviation score change from the baseline. Change from the baseline. And on the right side, it is the height SDS change from the baseline. And again, non-inferiority of somapacitan can be appreciated. This slide speaks of the IGF-1 data, and I probably won't go into the details of this because Professor Miller is going to cover this in his talk. But what it shows here is, once again, there is non-inferiority or the comparable. The rise in IGF hasn't gone beyond +2 ST, and both treatment modalities are comparable. Somapacitan efficacy was maintained at 3 years. So for those who were on somapacitan, those who were on daily, and those who switched, if you look at their data at week 0, 52, 104, and 156 weeks, they are very comparable. So similar height velocity between group was observed during 3-year treatment period. Now looking at the safety data now. So if you looked at adverse events, at 52 weeks, both groups, both arms had very similar SAEs, and they resolved, most of them, and they were considered to be unlikely related to the trial products. Adverse event, again, if you see, the events are separated out here as headache, nasopharyngitis, pyrexia, pain in the extremity, bronchitis, and vomiting. And in both groups, they are similar, and there's no difference. Antibodies. Whenever you have a new product, especially related to a protein molecule, you're very interested in knowing the antibody data. And here, as you can see, somapacitan was very comparable to daily GH. If you look at visit 4 and visit 7, which is week 13 and week 52, in the somapacitan column, there were 2 cross-reacting antibodies at 13 weeks and 4 at week 52, and there were none in daily growth hormone arm. And patients who had 2 consecutive positive antibodies were 2. So out of those 4 at 52 weeks, 2 of them were positive, as you saw at 13 weeks as well. Injection site reactions. So at week 52, the data shows that in both the groups, the injection site reactions, which consist of mild bruising, site pain, injection site hematoma, hypersensitivity, and swelling, were comparable in both groups. Somapacitan thus was well tolerated in children with growth hormone deficiency at year 3. So during year 3, a low proportion of the participant reported injection site reactions. No neutralizing antibodies were detected, and I think that's very important. There were no clinically relevant findings related to glucose metabolism, that is change in fasting sugar or HbA1c, and mean IGF-1 SDS values, about which you will hear more in Professor Miller's talk, were within normal range. Now, observer-reported outcomes. So what was reported by the caretaker as well as by the observer has been shown here. And to simplify this, the first 4 deep blue boxes and whiskers, you can say, are the observer reported, and the one at the bottom are the parent reported outcomes. And in both cases, you can see that it favors somapacitan. It favors somapacitan, whether it is reported by the parent or by the observer. So patient preference questionnaire showed that at 56 weeks, caregiver for subjects switching from daily to weekly said that 90% of those would prefer to have a weekly growth hormone injection. So to summarize from phase real 3 and real 4 trials, which I just showed you, long-acting growth hormone preparations include molecular changes to the weight and ionic changes, as well as the binding to other molecules. Primary and secondary endpoints show similar efficacy between somapacitan and daily growth hormone in real trials 3 and 4, which I showed you. Patient-related outcome shows a reduced treatment burden and somapacitan compared to daily growth hormone. Somapacitan was preferred by parents and caregivers when a child switch from daily to weekly growth hormone. An overall safety profile of somapacitan was similar to the well-known safety profile of GH and was considered to be non-inferior. So with that summary, I would like to end my talk and would hand it over to the chairperson.
Thank you, Prof. Vaban. That's very interesting, very clear presentation and introduction on the weekly growth hormone. And so I would like to remind all of you, if you do have questions, as you wish, you can also go to the microphone later after our second talk, or we also have Slido if you don't like to go to the phone to speak. I would like to move on to our second presenter, Professor Bradley Miller, who's going to talk to us on the optimizing the somapacitan, basically looking more on the IGF-1 response. Prof. Miller.
Thank you. Well, I'd like to thank the organizers for inviting me and Novo Nordisk for making this possible. So I'll be talking about optimizing somapacitan for pediatric growth hormone deficiency, focusing on the IGF-1 response, dosing, and monitoring. These are my disclosures, and as Professor Yazid and Professor Vaman said, I was an investigator in Real 3, or I'm sorry, in Real 4, and was the lead author of the publication, but also was an investigator in clinical trials for other long-acting growth hormone products. Vaman talked a little bit about the somapacitan structure, how it's been modified to have a long fatty acid chain that will bind to albumin to make it be able to last in the body longer, to allow for a once-weekly administration. And this is the same method of protraction that has been used in other molecules, including the insulins, as was mentioned. This is a cartoon showing the somapacitan mechanism of action. So essentially, it's a reversible binding of somapacitan with albumin. And then it's an interaction of somapacitan with the growth hormone receptor to activate the intracellular signaling. And that may happen with the albumin attached or without the albumin attached. And then we have the intracellular IGF-1 signaling, and we'll talk a little bit about how the profile of that IGF-1 changes in the daily versus the once-weekly somapacitan. The other important thing that I wanted to show was some of the data showing that somapacitan will actually bind at the local level and can get into the target tissue. And so what we can see in the upper left of, or upper right of the slide is looking at areas where somapacitan in red is present at the growth plate in the bottom part, right where you want it to do its job. And so it's a key that the somapacitan is actually getting to where it needs to go. And then in the bottom panel, you can see actually activation through phosphorylation analysis to show that the somapacitan was actually activating downstream signaling of the growth hormone receptor to get to that target. So there are some unique characteristics or concerns that arise when we think about a long-acting growth hormone. So anytime we change a molecule, we want to think about the immunogenicity. And Professor Vaman talked about the lack of neutralizing antibodies. We want to think about the ability of the molecule to get to the target tissue, and whether some of the molecules, because they're larger, might have difficulty getting into the tissue and activating the signaling that we're looking for. Are there fusion protein specific effects? Could there be a larger injection volume because of the molecule being larger and not being able to be concentrated? The next is the lack of experience of providers with the new therapy. And then I'm going to focus today on the lack of knowledge of dose adjustments necessary for individualization of therapy. In the clinical trial, there was very specific guidance on how we adjust the dose of growth hormone in children receiving the medication. But as we start to use the medication, we have to decide for our patients, what's that going to look like? And the key thing that I'll focus on today is how do we interpret the IGF-1 values? So I want to highlight that this is, already an art in terms of how we use the IGF-1 to guide our practice with daily growth hormone. But interestingly, because of the pharmacokinetics, IGF-1 monitoring and long-acting growth hormone is actually going to require specific knowledge of timing of the injection, timing of the dosing, and some information about what is the pharmacokinetics and pharmacodynamic profile. So big questions come up is when, after a long-acting growth hormone injection, should we actually draw those samples? What time point is best to represent a peak or an average IGF-1 response or to guide our dose adjustment? And what do we do if a patient doesn't show up when they're supposed to? And that's the key for me, because my clinic is on Thursday or Tuesday. If the patient takes their medicine on Sunday, then it's not always going to line up with a day 4 draw or a day 5 draw or whatever day we would like it to be. So to develop the models to try and help us understand this, there was clinical data from phase 1, the phase 2 Real 3 trial, and the phase 3 Real 4 trial that was taken together from 210 children with growth hormone deficiency. And then a PK/PD analysis was made to develop a support for clinical guidance on dosing and monitoring using this model. So these are the same clinical trials that Professor Vaman talked about, with Real 3 being the phase 2 clinical trial, Real 4 being the phase 3 clinical trial in children with growth hormone deficiency. And to just highlight that in this phase 2 Real 3 trial, it was a dose-finding study, as the professor mentioned, where there were 3 different doses of the once-weekly somapacitan compared to a daily dose of growth hormone. And I wanted to focus here on the IGF-1 levels. And these are average IGF-1 levels that were estimated using the model that we're describing. And so we can see on the left that the somapacitan trough, those are the actual values measured. And we can see the dose response of the 3 different doses. At the peak, we see a much more consistent dose response from the 0.04, 0.08 to 0.16. And then using the model to derive an average, we can see the same sort of dose increment. In the far right panel, you can see the daily growth hormone values, which are staying steady. And in the 0.16 milligram per kilogram per week, you can see that you're achieving IGF-1s near the mean and similar to what the daily values are. So now switching gears to the Real 4 clinical trial. This is the phase 3 pivotal trial for registration. And in this trial, as Vaman said, Professor Vaman said 200 prepubertal children randomized 2-to-1 to receive somapacitan 0.16 milligram per kilogram per week or daily norditropin. And one of the key things that I want to focus on here are the endpoints, which the professor mentioned the height velocity endpoint as the primary endpoint, but I'll focus on the IGF-1 standard deviation score values. So here on the left panel, we can see the baseline values before they start growth hormone therapy of any sort. On the left, we see minus 2.03 in the children who receive somapacitan and minus 2.33 in the children receiving daily. And then at the end of the 52 weeks, we have the 0.28 for the once-weekly somapacitan and the 0.1 for daily. And in the right panel, we can see that because at different clinical trial visits, we either obtained a peak or a trough value or a day 4 to 6 value. And so we can see at different times the peaks and valleys. you see with daily growth hormone that you quickly rise to a level and then you slowly go up over the course of the year. And then with the once weekly somapacitan, because we're measuring a peak value at that first measurement, you can see you get up to levels pretty quickly, and then you hover around that value. And it's those numbers that were actually used to derive the model that helps us estimate the average. And the estimated average is going to ultimately be that day 4 to 6 blood draw that we'll talk about a little bit more. So as was mentioned by Professor Vaman, the clinical trial, REAL4, phase 3 clinical trial, showed non-inferiority of somapacitan versus daily norditropin for the primary endpoint of height velocity at week 52. That was confirmed. The IGF-1 standard deviation levels were similar between the weekly somapacitan and the daily norditropin treatment groups at week 52, and the means were within the normal range of -2 to +2 standard deviation scores. And so I think it's very important that we're looking at replacement dosing, and we saw that the majority of those values were in the normal range. And the overall safety profile of somapacitan was similar to the well-known safety profile of daily growth hormone. So now I want to focus on this diagram to talk about that pharmacodynamic model. On the left-hand panel, you have a cartoon depicting how IGF-1 varies very minimally as you proceed through the week with daily growth hormone. And that's what we're used to. We can draw a level anytime somebody comes to the clinic. As long as they're taking their medicine consistently, it'll be a good estimate of their average IGF-1. Usually after about a month of therapy, we can start to see that they've achieved a reasonable average. But with weekly somapacitan, you're always going to have this peak and valley. And so number 1 there shows the maximum IGF-1 levels that occur around day 2. Number 2 at day 4 shows the weekly average IGF-1 levels. And then day 7 is the trough. And interestingly, they showed very similar weekly IGF-1 average standard deviation scores, as I mentioned, despite that very different profile of that IGF-1 pharmacodynamic profile. So using the models, we derived I'm not a statistician or a pharmacodynamic modeler. The team derived the values for calculation tables to predict the average IGF-1, depending upon the day that it was obtained. And so essentially, if you have a patient come in and they've took their dose on a Monday and they're in your office on a Friday, that's day 4, you're exactly at the average and you don't need to adjust anything. But if they draw it on day 2 or day 5 or day 6, then you have a calculator where you can add or subtract from the standard deviation score value to get the value that you need to use as your estimated average IGF-1. It's also, if you're if you don't have standard deviations available, there's also a ratio available for concentration values. And because this is just looking at the pharmacodynamic model, it should work for any assay because it's describing the change over time in the IGF-1. So it doesn't matter what your assay is, it's going to have the same sort of profile. And I think that's a key question. And this just depicts on the right the fact that we're using that mean value in the middle to try and subtract or add depending upon what time of the profile you're at to get to that average IGF-1 value for using that chart. So I wanted to throw in a case presentation. This is a patient of mine who's a 12-and-a-half-year-old female who was diagnosed at age 2 with growth hormone deficiency due to an ectopic posterior pituitary gland and stalk interruption. She's currently Tanner 5 and is on estrogen replacement therapy. And when she was on daily growth hormone at a dose of 0.3 milligrams per kilogram per week, she was missing about a dose per week. So we offered the once weekly growth hormone to them. And as she made the switch, her daily growth hormone IGF-1 was 314 nanograms per deciliter or minus 0.4 SDS in our assay. However, when she started once weekly growth hormone, her IGF-1 was 336 nanograms per deciliter. She was slightly older, so it had moved a little bit in terms of the SD score. But it was 40 hours after the injection, it was minus 0.5 SDS. So if we just looked at the IGF-1 that day, we'd have said, it's actually not in a bad range, it's probably okay. But she actually had the lab drawn close to the peak. And so essentially, this was overestimating her value. So when we take her estimated average IGF-1, we have a minus 0.5, but because she's at the peak, we have to subtract minus 0.8 SDS. Her average is actually minus 1.3, showing that she's currently being underdosed. So due to her low IGF-1 and her pubertal status on estrogen supplementation, the somapacitan dose was increased to 0.19 milligram per kilogram per week. And then her repeated IGF-1 using that dose was essentially right at the mean. And we've seen this in adults receiving estrogen replacement therapy with daily and once weekly growth hormone, that you need a higher dose to get the same IGF-1 effect. So the last part of the talk, I'd like to just talk about the flexibility of the dosing. So because the half-life of the growth hormone molecule and the half-life of the IGF-1 profile actually differ, there are different impacts on how taking a medication early or late will impact the profile. And so on the left-hand panel, we can see if we administer the dose 2 days before the regular dosing level, we actually have a slightly higher peak and a lower trough. And then we get actually back to steady state rather quickly. The same administration 3 days after the regular dose, you have a deeper trough and a slightly lower peak. But when you give that second dose, then you have a bigger peak after it. And it's actually not as big a shift as we would have thought because of the half-life difference of the daily growth hormone. So it's actually been labeled as saying that you can give the dose early or give the dose late and still be within a safe range. It's not recommended as a regular practice. You know, we want everybody to be consistent, but that if the dose is missed, that there's actually a window where we can still safely give that dose. Or if we're trying to switch, we're on a Monday consistently, we now want to do it on a Thursday, there are similar ways to adjust our dose without having a significant excursion of the IGF-1 values. So the last part that I want to talk about is our need for long-term safety and efficacy data. There's still some questions we have about daily growth hormone that we would like to continue to analyze in the long-acting growth hormone era. We also want to know, is adherence better on the treatment? Are our height outcomes better because adherence is better? Is there some other reason that we get better outcomes with once weekly compared to once daily? And so I was the Pediatric Endocrine Society representative on the consortium developing GlobeReg, and Professor Yazid was the APAS representative as well. And so this was a group that was coming together to have a investigator-initiated registry for children on growth hormone therapy. It's been live now for about 2 years. So you can be an investigator in this. You just have to reach out. Currently, we're gathering data on children on daily growth hormone, as well as some children on long-acting growth hormone therapy. There are different working groups that are developing different areas. So the adult growth hormone deficiency is ready to be launched, the Noonan syndrome as well, and very soon Prader-Willi syndrome is going to be launched. And then there are specific scientific studies, which I'll mention the somapacitan study here. So somapacitan registry was actually built to be part of this GlobeReg, where children that are receiving somapacitan in the countries where it's been approved are gathering data specifically for a 3-year recruitment and a 7-year follow-up for long-term safety in children with growth hormone deficiency, as well as to try and look at some of the other safety and clinical parameters that are available during clinical practice, because our real world practice is always different than what we see in the daily, in the clinical trials. So I'd like to summarize by saying the ideal day to measure an IGF-1 is on day 4 to get that average value. However, an average IGF-1 can be measured from a blood sample taken at any time during the somapacitan dose using the published model. Due to the pharmacokinetics of somapacitan, there's actually flexibility in the timing of administration. We want it to be consistent weekly, but if there is a need to shift it for a sport outing or a vacation, there are those opportunities. I think it's going to be really important to collect long-term safety and efficacy data for somapacitan, and GlobeReg is an independent registry intended to capture that data both for safety, efficacy, and in the future, patient-reported outcomes for children receiving both daily and long-acting growth hormone. And there is a specific somapacitan module available in GlobeReg for that purpose. So again, thank you for your attention, and I look forward to questions at the very end of the process.
Thank you, Prof. Miller. So I'm opening the floor for any questions. Yep, please.
Very nice presentation by all the three. So my first question is to Professor Miller. There are a lot of troughs with when you use long-acting. In the past we had one long-acting, which was provided by, I think, this company in Korea. So we have a lot of troughs we used to see with the patients in this IGF-1 troughs and all that. So what do you think there'll be any problem in the future with this such troughs occurring, so much of troughs as compared to the daily growth hormone?
So, thank you. So I do think that with the long-acting, that the average IGF-1 is going to be the best predictor of both efficacy and safety with the IGF-1. So I don't think we're going to have there is some excursion, but it's not going into ranges that I think that we're going to be worried about. I think gathering the data in the GlobeReg or other registries that will do that is going to be really important to answer your question of, because we're having this less physiologic profile of IGF-1, are we seeing new side effects that we didn't see with daily? We know daily is not physiologic to begin with, but we know the weekly is even less so. And so I think it's gathering that data long-term is going to be key to answering your question. But in my experience and in the clinical trials so far, that change hasn't had a negative effect.
Okay, second question is that, this is for GHD, right? So there are so many causes of GHD. You have GHD, isolated growth hormone deficiency. You have multiple pituitary growth hormone deficiency. You have GHD in post-craniopharyngioma operated. Are we going to use in all these patients with GHD, or is it only for isolated growth hormone deficiency?
So it is approved for any child with growth hormone deficiency, and so any of the ones that you mentioned would be candidates for that therapy. They're in the guidelines, there's been some questions as to whether cancer survivors of any type should be treated with more caution. And I think we already treat them with more caution with daily growth hormone. So I think, I would love to have studies to show that safety in those populations. I actually treat a number of cancer survivors in my practice and have started to treat a small number of them who are very far out from their cancers, but have very severe growth hormone deficiency with once weekly therapy.
No, why I ask this question? Because the Growth Hormone Research Society has changed the guidelines on the starting of growth hormone in patients of craniopharyngioma.
Yes.
So they say wait 6 months. Before it was 2 years, 1 year, now 6
Yeah.
to 9 months. So I think we should be very cautious in using the long-acting growth hormone in these patients of craniopharyngioma, which we know recurrence can occur.
So I think we need the data to answer that question, and I think Professor Mueller gave an excellent lecture yesterday about craniopharyngioma, and there's a lot of questions as to whether growth hormone therapy, replacement therapy, not pharmacologic therapy, has any negative impact on the tumors. And I think caution is 100% appropriate, but I think there's still a question there. I work in our cancer oncology clinic every Tuesday afternoon with the oncologists, and we talk a lot about when and if we should be treating children with growth hormone for each diagnosis, including craniopharyngioma.
So what about patient PWS?
So
with
Prader,
UHD?
so Prader-Willi syndrome, children have growth hormone deficiency with Prader-Willi syndrome, could be candidates. I think, I don't know if there will be registration trials specifically for Prader-Willi from any of the companies. I don't know if that's a plan. I have offered it to some of my patients with Prader-Willi syndrome, but I haven't yet started in any of them. And I would love something like GlobeReg to capture the data for physicians who are treating children with Prader-Willi. They are growth hormone deficient, so I think that's, if they're growth hormone deficient, they would be appropriate for that category.
Thank you.
You're welcome.
All right, that's very good questions that we have. Yes, please, before I move on to the slide.
Thank you.
Yeah.
Thank you, Vaman. Sir, you just showed that in real 4 study, I mean, in long-acting growth hormone, there is a severe side effect in 3% of the cases, while in daily it is just 1.5% of the cases. So what are those serious side effects? Because that has to be enumerated. And this is possibly because, number of cases in that cohort was much more than 132. And if we look at the daily, they were just, I think, 56 or not that much.
Yeah, I think they all come under the category of serious adverse events, but none of them are life-threatening. We had shown a split of that as well, and if you notice,
so that was the severe.
That was the essays.
Okay.
Yes.
So I thought serious means
severe
means
none of them had to be admitted or went into ICUs or anything, and no life-threatening events.
Thank you, sir.
I have just question about the cartoon. Growth hormone binding with albumin and then induction the intracellular elements to produce IGF-1. Then how the action is prolonged? If it binds with the albumin or if it doesn't bind, the same thing will be produced. Binding should disallow it to engage with the induction element so that the action will be prolonged.
So it's an excellent question. And so the ability of the growth hormone to bind to the albumin is what prolongs its half-life so that it stays around longer. The affinity for the albumin is quite high, but it can leave the albumin molecule and go to the growth hormone receptor. If it does that, it's likely internalized and pulled out of the system. So just like any growth hormone from daily, if it sits on the receptor, it gets pulled in and destroyed. So it's only the ones that are, would normally be cleared by the kidney and by other things that are being prolonged by the albumin binding so that it can stay around and have its chance to get to the receptor. So that's the mechanism that is working to prolong.
What is being shown that it binds with the albumin and then the bound form is then bound with the induction element.
So there's actually been shown both that that the albumin growth hormone somapacitan combination can bind to the receptor, but it doesn't have to be attached. So if it's in a smaller tissue where albumin is being excluded, the growth hormone somapacitan molecule, just like I showed on the receptors at the growth plate, they're getting to the growth plate they're leaving albumin behind because albumin's too big to leave the blood and go to the growth plate. So we know it has to leave the molecule to get to those target tissues.
Thank you.
Yeah, very important question. Thank you. And to answer the other question from the audience, I think whenever a child is in ICU, we recommend discontinuing or pausing on the growth hormone therapy. So just to emphasize that.
There are a few questions here on Slido. I'm just going to take a few of them. Okay, thank you for the talk. Are there any medications that would affect the IGF-1 readings if given concordantly? Do we know?
So the amount of binding to the albumin, it doesn't appear that there's any interaction with other albumin binding medications affecting the IGF-1 or growth hormone levels.
Okay, then this question for Dr. Varman. And injection site pain is difficult to manage. Pragmatically, how do you mitigate?
Right. Amongst the patients that we have enrolled in our center, injection site pain was a little more common in the somapacitan group. But I don't think we ever had to use any local medications or painkillers for that. It subsides on its own. So although it's reported to be more severe than the daily, I don't think it's a management issue really.
I would agree. In my experience, the same.
Yeah. The other question on the how long after adjusting, increasing or reducing the long-acting to assess back the IGF-1 level in case the clinician is concerned?
So typically I do it a month later, but based upon the pharmacokinetics, I think it can be a week or two because the steady state is actually achieved quite quickly.
All right, I have two more questions here. So when are we going to have this molecule in India? I think the little bird has whispered to me that you're going to get it by the end of the year. So much earlier than in Malaysia. So
the end of which year?
2024, end of this year, not next year. Okay, so yes, it's going to come very soon. I think thanks to Prof. Varman and some of you who actually does the study in India. I think that's really helpful because currently in Malaysia we are running the Real 8 and Real 9 for the non-growth hormone deficient patients. Yeah. All right, there's one question that just come in. Do we still ask the child to inject long-acting growth hormone at night, or could it be injected in daytime?
I don't think it's going to matter because it has got a prolonged action. But I would still say that if they maintain consistency in the timing, whichever is suitable to them, it's probably not advisable to take it once in the morning and once in the evening. But yes, it could be given at any time of the day. Sorry? Sorry, what's he saying?
Can you use that?
So the window period is 3 days.
Yes.
So whether you give in the morning, the evening, next day will not
Yeah.
make a difference. So why should we talk that morning and evening stuff?
Yeah.
Agree.
It's 3-day window period. Yeah.
I just like to know when they did it to help me estimate the IGF-1. Yeah. So if they did it in the morning or they did it at night, it's just helpful to know that answer. I don't care which, just that I know.
Sorry, I got the wrong info. So the little bird gave me wrong info. It's for the other things that's going to come to India by the end of year 2024, but not somapacitan. But I believe it's going to come very soon because it's already there.
I think the bird doesn't know when it's going to come.
Yep, you got me. All right, there's one question here which is I think quite I'm not sure it is very sensitive or not, but the cost. Whether is there a lot of difference between daily and weekly, and I think the medical people here may not know about it. Yeah, when the time comes, then we got to know about it. Yeah. All right. So we have all the questions. I'm just going to open one more time. Yes, please. Yeah.
I have a question for you, actually.
course.
And the question is, have you had any patients on whom you had to reduce the dose because the IGF-1 was going too high?
I have. And so that definitely has happened, and it's been particularly in younger children with more severe growth hormone deficiency. And so my colleagues have said that some of their children, as they enter puberty, have actually needed to reduce their doses as well. Counterintuitive to what we have done in the past or thought in the past that you actually need more growth hormone during puberty, they've actually seen dose reductions. I haven't had, I mean, I gave the example of the one young woman who's on estrogen therapy that we had to increase the dose, but I haven't had many pubertal children, but yes, have had to.
So does it growth hormone stimulation test the results of growth hormone if the child is GH is 2 or whether it's 5 or 6 or 7, just cut off of 7? So does it make a difference in the response with your molecule?
So we actually have a paper coming out that is answering that question very soon from the clinical trial data, and we used thresholds of 3 and less, 3 to 7, and 7 and above, because this trial did include people internationally, some that were between 7 and 10. We could see a difference between the children who were 3 and below from the other two groups. We couldn't tell the difference between 3 and 7 or 7 and 10. So definitely the 3 and below, difference in growth response compared to the people 3 and above.
Just like daily growth hormone, almost similar to daily growth hormone.
Agree. I don't think it's a difference compared to daily. I agree.
All right, that's one question here. I'm really, I mean, it's for me, okay? Because tomorrow we will have a transition talk, and there's nothing about growth hormone treatment. So do you think there's any need for us to use the long-acting for the adolescents during the transition?
So I think that is an important conversation, and I hope that at some point we can have clinical trials or capture data from GlobeReg or other registries to answer that. I do think that children in transition should be treated, and there is one long-acting that it's approved in adults that we can transition them to as well. So I think it's a long-term need.
All right. I think we had a very good talk from both Prof. Varman and Prof. Miller. Give them a big applause. Thank you so much for that. Yes, I hope that also gives us an idea of what is long-acting growth hormone and how we use it, what are the possible side effects, how effective it is, the safety profile and all that. I believe when it comes to the need of patient, we would go for the best medication that is available with the least problems, I would say, in terms of safety or even pain, because these are all about injections. 365 injections per year versus 52, and I'm sure everyone will opt for the smaller number. Right, so thank you very much to both of you. Yeah. Okay, so we need to move on. I'm just gonna go back there. So it is my great pleasure to introduce our next speaker, who's gonna talk to us on managing type 1 diabetes with the new generations of insulins. This none other than Dr. Archana Arya. So she has been doing pediatric endocrinology for more than 25 years. I was surprised to see her just like she looks so young with the spectacle, but yeah, there she is. A lot of work that has been done. She does a lot of work on diabetes, and she has been in the professional membership in ESPE, Endocrine Society in the US. She also had executive roles in member of the editorial board of Asia Pacific Journal of Endocrinology. A lot of publications, a lot of research. I think I've read somewhere that she has been the honorary secretary or treasurer in society in ISPE. So yeah, today she's going to talk to us on managing type 1 diabetes with new generation insulins, and I would love to hear from her. Prof. Dr. Arya, please.
Thank you. Thank you so much for the kind introduction. And I think this is a big switch in the topic. And today, now we're talking about what's actually available over here. And these are my disclosures over here. So today I'm talking about the new generation insulins and their use in type 1 diabetes. And I think you all, being pediatric endocrinologists are well aware that there are a lot of difficulties in managing type 1 diabetes in children. Their lifestyle is different from adults, very variable routines. Sometimes they have exams, holidays, some are into sports. So every day is a different day for them. And usually they avoid frequent blood glucose monitoring. There is less use of sensors. Difficulty in injecting and monitoring in school is a big problem in our country, at least. It's a little better in other countries. And of course, the non-physiologic insulin preparations have been a problem in the past. And this is improving now, and that's what I'm going to talk about. So we all know that the risk of progression of microvascular complications increases tremendously with poor control. As the HbA1c rises above 7%, you can, which is the pointer here, can I use it here? Yes. So you can see there is a rise in the microvascular complication, and this was well documented in the diabetes control and complications trial. So glycemic targets were set for these children to cut down on the risk of these complications. And these are the targets which are recommended by various societies, and the ISPAD recommends that for those who are monitoring with finger stick, the blood glucose should be between 70 to 180 milligram per deciliter, and lower, the fasting should be from 70 to 144, and the HbA1c should be maintained between 6 to 7%. I think the newer guidelines are bringing it down to 6.5%, if they're on automated insulin delivery system and with sensors. And for those who are on CGM, it is recommended that more than 70% of the readings should be in this range of 70 to 180, which what we call as time in range. Now, all these this well documents that intensive therapy is more beneficial than conventional therapy, but initially this was at the cost of increased risk of hypoglycemia. And it was a problem to actually achieve these targets, but now this has become simpler to achieve these targets because of superior technology for blood glucose monitoring, that is the CGMS. The insulin delivery systems have improved. We know with insulin, the new insulin pumps are much easier to use, and they bring about better control and physiological insulin preparations, which is most important because at the end of the day, it's the insulin that is controlling the diabetes. So today I'll be focusing on the first generation basal insulins, what were the pros and cons, and what were the lacunae which needed to be filled. And then we talk about the new generation insulins, which are taking care of the problem we face with the old generation insulin, that is the ultra-long insulin and the ultra-fast insulin. So starting with the first generation basal insulin, I think you all know glargine was the first basal insulin that became available, the first generation analog, and maybe some people in this audience never used the NPH insulin, which we used to use for managing diabetes prior to this. But when we did our fellowship and started work, we used to use NPH and regular insulin all the time, and the control was very poor. There were a lot of problems with the NPH insulin. So the basal analogs changed the management of diabetes. Now, insulin glargine U100, the structure is by substituting the glycine for asparagine at A21, and 2 arginines are added to the carboxy terminal of the B chain. So basically, it's a change in the structure of natural insulin to prolong the action. And this precipitates as microcrystals. This is a subcutaneous injection, and it is at an acidic pH of 4, and this causes a little burning while injecting. It gets precipitated at the pH of 7.4 in the subcutaneous tissue, and then there is a slow dissolution of free glargine hexamers, which results in a protracted action of glargine. Then the next insulin that became available was the insulin detamir, again a first generation analog. Here a fatty acid, myristic acid, is bound to lysine amino acid at position B29, and this is a neutral pH insulin. And one of the mechanism of protraction besides self-association is extensive albumin binding. As Dr. Vaman just mentioned, that albumin binding is a very good technique to prolong the action of various drugs. So with these first generation analogs, the response was way better compared to the NPH insulin, which was being used prior to this, and there was a risk reduction of hypoglycemia by 20 to 46%, as you can see. So it actually changed the lives of patients. Initially, they were very apprehensive. I remember to take 4 shots because we used to combine regular insulin with NPH in the same syringe and give it those days. And to tell them to switch to 4 doses was a very tough task for me. But once they tried it, nobody went back to the old regime because it was so much better. Also, there was lower day-to-day glucose variability compared to NPH. This is NPH and glargine, and this is detamir. So that also improved the results. But still, there was some problem with these first-generation analogs. First of all, they were not truly once daily because unfortunately, none of them lasted for a very long time. We thought it would work for 24 hours, but that was not the case. Most of them lost their effect by 18 to 20 hours. So the children had to take them at a fixed time to make sure there is no delay. Secondly, it was not truly peakless either. It used to have a slight peak and leading to high nocturnal hypoglycemia. So the initial recommendation was to give it at bedtime, and most of the patients came back with lows when we started them on glargine. And then we had to change the timing of the insulin in these children. I used to give it in the evening or afternoon so that there was no nocturnal hypoglycemia. And there was some amount of variability present. So the new generation analog that we have now, the ultra-long insulin that is being used very often, I'm going to discuss that. That is insulin degludec. So this has zinc and phenol attached to it, and it's injected in a dihexamer formation. As soon as it's injected, it loses phenol, and this phenol depletion after the injection results in multi-hexamer chains formation. The zinc in the molecule diffuses slowly, and it causes individual hexamers to disassemble and releases dimers and then monomers. And these monomers are absorbed from the soluble depot into the circulation. So if we compare the basal analogs, basal insulins, here we have NPH, glargine 100, detamir, and degludec. You can see that the onset of action is the earliest compared to the rest. It is 30 to 90 minutes. The peak is minimal, and the duration of action is more than 42 hours. There is lower within-day variability versus the glargine. You can see degludec has a lower within-day variability as well as a lower day-to-day variability. You can see over here. Coming to the efficacy and safety of degludec in children with type 1 diabetes. The summary of the Young 1 trial, which was done before it was approved, they had seen the HbA1c, fasting glucose, confirmed hypoglycemia and hyperglycemia with ketosis, and they found that degludec achieved equivalent long-term glycemic control with similar rates of hypoglycemia, but hyperglycemia with ketosis was significantly reduced in these patients. And the reason for that was because of the longer duration of action. So if people would forget to take their dose or they would get delayed, the chances of hyperglycemia and ketosis were much lower. So that was the biggest advantage of this insulin. So this is a very short case that I have of a 9-year-old girl, Tanner 2, who had a body weight of 36 kgs, and she was diagnosed with type 1 diabetes about 6 months ago. And she was on a basal bolus regime with a total daily dose of 40 units. She was getting glargine 17 units at bedtime and 7 to 8 units of aspart before each meal. She was on a fixed carb diet. So you can see her readings here. Her blood glucose was very high before dinner. Her post-lunch was good, but before dinner was high. And at 3 a.m. she was getting hypoglycemia, and of course she would take something sweet, and then the fasting blood glucose would run high every day. So we switched her to degludec. We lowered the dose a little because you need slightly lower doses with degludec, and you can see that the effect, the blood glucose improved tremendously because it was the hyperglycemia was being caused because of the wearing off of the glargine, and the nocturnal hypoglycemia also improved because that was because of the slight peak that glargine had. And obviously all the readings became better and the control improved. So just to comparing the three basal insulin analogs, degludec has the longest duration, 42 hours. Flexibility of timing is there. The delay doesn't affect the blood glucose level. Lower doses are needed. It reduces the hyperglycemia or ketosis due to the missed dose, and it can be mixed with other insulins. What happened here? Yeah, okay. So let's take a quick look at the ultra-fast insulins in children. So we have been using regular human insulin over the years, which was the closest, the most physiological insulin we thought years ago. But if we compare it to the normal insulin secretion from the pancreas, there is a huge difference. The onset of action is much later. It has to be taken before meals. The peak is not as good. And the offset is also after a long time. Now, following this, some fast-acting insulins like aspart and lispro were available, which had a faster onset of action, a better peak, and a faster offset. But still, it was not close enough to the normal insulin secretion. And following this, now we have an ultra-fast insulin, which is probably the closest to the physiologic secretion of insulin from the pancreas. So, faster acting aspart is the name of the insulin, and this is a relatively new formulation, but it is the same old molecule of insulin aspart. They have added niacinamide to modify the absorption, and arginine is added for stability to improve the action of the insulin. Sorry. As you can see over here, that in faster aspart, the early monomer fraction is far more than it was in aspart or in the human insulin. So that is why there is a quick onset of action. So compared with the insulin aspart, it has twice as fast onset of appearance in the bloodstream, twofold higher insulin exposure within the first 30 minutes, and 74% greater insulin action in the first 30 minutes. The trial for this is the Onset 7 trial, where they had used the faster aspart at mealtime and post-meal also. So in young toddlers, we like to use insulin post-meal because we don't know how much they're going to eat, or they eat very slowly. And all the same is true for children with eating disorders. So both the timings of faster aspart were compared with insulin aspart. And you can see in terms of the results of this trial that the mealtime faster aspart provided superior HbA1c control compared to the aspart insulin, and the post-meal was non-inferior to the, it did not improve the A1C, but it was non-inferior. So we can use it post-meal in children. They also found that there was an improvement in the time and range in children who were on multiple daily injections, and in adolescents they also found an improvement in the time and range as well as a reduction in the time above range. And in those who were on a sensor augmented insulin pump, they found there was an increase in the time in range, and the time above range also decreased. And most patients were very happy using it and wanted to continue using this insulin in the pump. Sorry. The ISPAT statement on use of faster ISPAT in the pump is that the concentration is tripled when we administer it via the insulin pump CSII, and this pronounced effect may be due to the continuous influx of niacinamide by the basal insulin rate. So adaptations have to be made when you switch over to this insulin in a child who's on the insulin pump in the basal rate as well as the bolus type, because it works much faster than the other insulin. And just a last short look at how the profile of one of my patients was. A very obsessive parent who kept scanning the CGMS constantly. Thanks to the CGMS, people start worrying about that little peak which comes after the meal. And people will keep, when they started using it, they would keep calling to say, oh, the blood sugar is running so high, it takes so much time for it to come down, isn't that dangerous? When you educate them well, they're worried all the time. So you can see how often this patient was scanning, and they would keep scanning the CGM till the blood glucose normalized in this child. So he was on degludec and aspart. So we shifted him to the faster aspart, and you can see that the curve was flatter, and the immediate post-meal hyperglycemia improved, and his time in range improved, and so did the scanning. Didn't change too much, I can see, despite that. So they're still the same after so many years. They keep doing that all the time. But it just shows that we have a quicker action, and it does cut down, improve the time in range. So just to summarize the benefits of faster and faster aspart, I've already mentioned most of the things. Flexible timing, 2 minutes before to 20 minutes after the start of meal. Convenient for children who don't have the patience to wait for their meals after taking their shot. Useful for those who need post-meal dosing. It reduces the risk of hypoglycemia due to delayed meals, because sometimes they take the shot and the meal gets delayed, so it cuts down on the risk of hypos over there. Improves the post-meal spike, and also prevents late hypoglycemia, which can be a problem with the regular insulin at least. And a rapid decrease in blood glucose in cases of hyperglycemia with ketosis. If a child has ketosis and we are worried about decay, it will bring down the blood glucose more rapidly. More precise calculation of dose can be made based on the carbohydrates consumed. Dose can be repeated for snacks in between meals without worrying about insulin on board because of the quick offset. But additional doses may be required for snacking because it doesn't last for very long. For children who want late snacks, they have to take another shot. And it's approved from the age of 1 year. And I think I'll summarize. I've said most of the things that ultra-long basal insulins do provide: better glycemic control, less hypoglycemia, and flexibility of administration, and improved coverage throughout with reduced within-day and day-to-day variability. And in the control trials and real-world data, we saw faster aspart includes the lower time above range and increases the time in range, and results in effective control of HbA1c, postprandial glucose, and comparable rates of confirmed hypoglycemia. Thank you.
Thank you.
Sorry, I went a little fast, I know.
That's fine.
But
Thank
we're
you.
running late, I know.
Yeah, thank you very much, Dr. Arya. I think that's a very informative talk, and I think I also like to thank you for sharing. Yeah, I think that's very important. When you look at the real world, what happened to our patients? Yeah, the use of ultra long and ultra fast acting do give them some flexibility and also improve in terms of their metabolic control. Just like to open the floor for any questions that anyone has. Nope, no questions from the floor. Just want to ask you a bit on this. I mean, I know that you have mentioned about the use for a certain group of patients avoiding nocturnal hypoglycemia, and those who you give the injection after they have finished their eating. So in practicality, how difficult, I mean, how many of our patients having that kind of issues, and how does this work with them?
So mostly toddlers, mostly the young kids, they take a long time to eat also. First they're unpredictable, of course, we all know that. But I would say a 2 to 3 year old child will take at least 30 to 40 minutes to finish his meal. That's how they're fed here, with somebody feeding them. So if we inject just before the meal, then the insulin will peak before the child has probably had even half his or her meal. So we recommend that you give it after the meal, but if they're taking too long, if it's like 40-50 minutes, then it may be a good idea to give it somewhere in between. Otherwise, again, we lose the benefit of the insulin. So, again, it varies. I think the insulin regime has to be tailored based on the child's lifestyle. Every child is different, has a different lifestyle, and whatever insulin goes best with their lifestyle is what we need to choose.
I think the use of the long-acting insulin, that really helps. I know you put it there is 42 hours of work, but I believe there's just no recommendation to use every other day, right?
No, so there was a trial with every other day where they found that it was well maintained, but it's still not a recommendation. I think there was just one study, and that's the first question when I tell people that it's long acting. So the first thing they say, if it lasts so long, can we give it every other day? But we tell them, no, you can be a few hours here or there late, that's fine, but try to stay with the same timing, because here if you say, okay, 2 hours late is okay, they'll probably give it 5 hours later, So, but yeah, the weekly ones will be coming, and hopefully if they're good and they get approved, we could use them.
I think that's also, I mean, from using the previous long acting, usually you tell them before bed, or if you want to use it in the morning. I saw that you actually give your patient in the afternoon.
Yeah, because when they come from school, first thing is I tell them to give 2 together, so that you're not injecting them 4 times. Still 4 injections, but at least you don't have to inject them 4 times in a day. It kind of cuts down on the hassle of the parents as well as the child. And then, if they get delayed or they forget at night, so most kids, when they come home from school, they'll have their lunch, and it's just easier to do it that way, I feel.
I think when we talk about insulin injections, a lot got to do on how we manage and how the parents accept what we discuss with them, right? It's more of the real world kind of situation rather than just the one that you see in the study. It differ.
Absolutely, absolutely.
Yes. So any more question or any remarks from anyone? And I believe this is the real the little bird telling us that it's going to be here, right? The Fayaz is going to be in India. It's already here. Yes. Okay. That's why I was saying that I'm very sad that it's not happening in Malaysia. It's not coming.
It's been here for a while, and actually the cost is less than insulin aspart. It's in India at least, so it's more affordable than the aspart for those.
It's more affordable. It works very well. You can use before or after the child eat, especially the toddler. So I think there's a great flexibility in the use of it, and the variability to me it looks very much lower in terms of the absorption and all that. If you don't have any more questions, I'd like to thank Dr. Arya for the very, very insightful, I would say. The sharing of the case to me gives us a lot more of information when it comes to using the insulin. And I would like to thank Novo Nordisk for giving us this opportunity to listen to the very well-known speakers in their field, both on the growth hormone as well as on insulin, the new generations. Thank you very much to everyone who stayed till the end of the day. Have a good dinner tonight. I think APES have a dinner tonight. So thank you very much to all, and I'll see you again tomorrow. Bye-bye.